Hi, my name's Laura and today's video explores how we can better care for patients with learning disabilities. I'm an adult nursing student and alongside my studies I work as a support worker for people with a mixture of complex learning disabilities. And before I start, I'd like to say that this video is not targeted at any group or individual, but is rather a reflection of what I've witnessed and researched with the aim to raise awareness and give guidance. So as nurses, we are taught to provide humanised and person-centred care to all of our patients without judgment or discrimination. However, there appears to be a generally negative attitude towards patients with learning disabilities, noticeably those whose disabilities are more profound and complex. To me, this is the result of inadequate education regarding learning disabilities, which contributes to poor care and 1,200 avoidable deaths each year. The NMC code states that all patients should be treated as individuals with respect and dignity, highlighting how humanised care is central to nursing education and practice. However, this patient group is still significantly marginalised, as shown during the COVID-19 pandemic. This is further stressed in the Learning Disability Mortality Review, stating that people with learning disabilities are dying at 3.6 to 6 times the general population's rate. As a result, 1.5 million people in the UK are continually being let down. So why is this happening? So, despite patients with learning disabilities being vulnerable due to their lowered capability to defend themselves from harm, they are not viewed as such. Thus, they are not placed into a separate group that highlights their differing health needs to the general population, which has resulted in an insufficient training and education being provided. This education gap is highlighted in a Freedom for Information request that has been sent to NHS trusts and universities. The results show that 47% of hospitals do not incorporate learning disability information into staff training. Additionally, 22% of universities did not offer training on reasonable adjustments for people with learning disabilities. Making reasonable adjustments falls under the 2010 Equality Act, so as professionals we are accountable for making sure that reasonable adjustments are made for our patients with learning disabilities to avoid discriminating against them. But how can we do this if we haven't been trained? Todres and Peers developed a framework that aids the provision of humanised care, which can be used to guide nurses and education providers in providing better care for patients with learning disabilities. The first pillar in this framework is embodiment and reductionism. Nurses can easily subject these patients to reductionism by viewing them with a narrow mind, only recognising them for their disability. Reductionism can also occur when nurses assume that people with learning disabilities lack capacity. To provide humanising care, we need to practice embodiment, where we encourage the person's dignity and values by not making assumptions and treating them with the same respect and dignity as any other patient. It's also important that when you receive a more complex case and more complex person with a more complex learning disability into your care, that you complete the necessary mental capacity assessment without the presumption. And to treat them with the same dignity as any other patient, we need to be open-minded and see the person for who they are and their health needs outside of their learning disability. Humanisation can also occur when a patient's agency is promoted. Patients with learning disabilities are often pacified when nurses remove their choice due to the assumption of capacity or communication challenges. It is important to remember that many patients with learning disabilities will face communication difficulties, and it is down to you as their nurse to encourage that agency by finding an appropriate communication method. Poor communication and lack of choice is isolating for the patient. Through using the correct communication aids, we can enable embodiment, which allows the patient to be more involved in their care, again maintaining their dignity and choice. Additionally, as a patient's sense of place can be easily removed when nurses do not advocate freedom and comfort through not being aware of physical and communicative needs. For many patients with a learning disability, the familiarity and security of an environment plays a significant role in their psychological well-being. Outside of a patient's tolerance, environmental factors such as noise levels, temperature, and familiarity can lead to distressing emotions and behaviours. When a nurse cannot understand why a patient reacts to the environment in such ways, the patient is viewed as a nuisance. Disruptive behaviours are often dealt with incorrectly again causing dehumanisation. By using objects of comfort and familiarity, using the correct communication methods, and being aware of environmental factors that may be overstimulating, nurses can help patients develop their sense of place. If a patient cannot understand their sense of place, their sense-making abilities can become impaired. Again, this can stem from ineffective communication between the staff and patient. As a result, the patient's sense-making becomes impeded as they cannot be aided in finding the meaning in different things, which can leave them estranged in an alien environment. This can be another trigger for distressing emotions and behaviour, which unfortunately causes the patient to be wrongly used as a scapegoat. This lack of education and understanding causes unwarranted negative attitudes and prejudice against patients with learning disabilities, especially when they exhibit behaviours that challenge or are perceived as a nuisance. So during the COVID-19 pandemic, blanket DNARs for people with learning disabilities disregarded the future lives of thousands of people. This took away the humanising practice of treating a person's past, present and future. Because patients with learning disabilities often have more complex health needs than the general population, us nurses should aim to preserve their quality of life. Unfortunately, problems with the provision of advanced healthcare, including planning, adjustments as needs change, the provision of services, all causes premature deaths. This loss of personal journey is widespread, which can lead to poor care and poor outcomes. Poor care outcomes are also associated with objectification, which is when people with learning disabilities are viewed narrowly as a diagnosis or number. By being labelled, objectified or stigmatised by a system or healthcare professional, patients with learning disabilities can become frustrated, stereotyped, embarrassed and excluded. Nurses must resist homogenization to prevent inadvertently dehumanising patients. Due to inadequate education and experience, some nurses are underskilled to provide care for this patient group. Providing mandatory training should be at the forefront of nursing education, especially as revolutionary shifts in how we care for this patient group have given them a higher life expectancy. As a result, it is estimated that by 2030 there will be 1.2 million people with a learning disability aged 60 years or older. These statistics show that the need to care for this patient group will rise. Nurses will be expected to care for this ageing patient group as their needs move away from residential care and more towards nursing care as they age. Therefore, implementing specialised training, policies and awareness from local trusts must occur rapidly. As nurses, we can start at the basics and utilise the knowledge given to us by hospital passports and carers as a grounding point for individualised care. Local trusts need to make learning disability training mandatory for all staff, and it should be refreshed annually to keep up to date with changes in best practices. However, the NMC is ultimately responsible for the quality of nurses on their register. The NMC has allowed the quality of care for this patient group to fall by not incorporating enough training into the courses of student nurses. If we are not taught how to provide care for this patient group during our training, how can we adequately meet their health needs when we qualify? MenCap has already brought forward this call for adequate education and training to the government with the Treat Me Well campaign. I believe this campaign also needs to be brought forward to the NMC and local trusts, calling for both to require all registered nurses to receive training on learning disabilities. I can't understand why education regarding learning disabilities has been repeatedly overlooked, especially when so much training has already been implemented for other equality and diversity subjects. Thank you for watching.